Evening once again. It is yet another day in the Decency podcast, and today we are bringing to you the emergency perspective of nursing in the US. So you want to see what it feels like being an emergency room nurse. Today is a great day to learn that. And then this is coming to you from your one and only vendor of good news. And today we have a distinguished personality in our midst. He's one of the renowned nursing persons that we know. He has been so resourceful in some of our groups, giving information, especially when the retrogression hits. And then he has also been very resourceful, helping other nurses, that are here in the US. So today we have the pleasure of meeting Mr. Isaac Gospower, who is an entrepreneur. I think some people call it nursepreneur, but I don't know if there's any word like that. But he's an entrepreneur, and then he's also a nurse leader. He has been doing a lot of things in the nursing community here in Nigeria, and even some people here in the US. So I don't want to, take so much time to introduce him and say so much about him, but I know that when he starts, he's going to definitely touch on some points that I have missed in his introduction. So today we are here again with Mr. Gospel. How are you doing today?
Good, everyone. Good. Good evening, everyone. A happy weekend.
Good evening, man. You came in with your Manchester United hat.
Yeah, I can't wait. We won yesterday.
Just know that victory is just it may not last the next season. Okay, so just okay. Well, so how is your area? How is your place? How are you doing? I think you're in Texas, right?
Yes, at the moment.
Texas today, hot, cold?
It's relatively warm, just like Nigerian weather, so no difference.
All right, sounds good. Nigerian weather. So those that want to still be in Nigeria in USA, you see, some people said Texas is just like Nigerian weather. Well, here is also warm actually. So I'm in Virginia. I'm also rooting for my Virginians, my Virgins. All right, man. So I would like you to I know you work in the ER, and I know there's been, a lot of experience that you've gathered. You've been in the US for some time now. So I don't want to ask you, question one by one. First of all, we're going to get to that, but I want you to share with us a regular lifestyle of an ER nurse from start to finish, like from the time that you clock in to the time that you clock out. What is your role like? What is your shift like? I know you prepared something for us, but if you can coin everything together by just running us through what it means to be an ER nurse in one-day shift in the US. Go ahead, sir.
All right. The emergency room is quite complex and quite unique in US. It's quite different from what we think or what we used to practice in Nigeria. Started from clocking in, you have what we call a huddle. A huddle is where everyone assembled together. We have what we call the charge nurse. The charge nurse is the one who is in charge of the shift, who makes out the routine for the ER, who kind of share roles and responsibilities for all nurses, because we don't want the situation whereby everybody's running helter-skelter, you don't know what to do. So there's what we call shared roles and responsibilities, whereby everyone has an assignment or where it's been assigned to do. So the ER in the huddle, you are being given an assignment of for instance, you can say Decency, you're gonna be in charge of the trauma room. Tony, you're gonna be in charge of the triage room. Then Sam, you're gonna be in charge of acute care room 1 to 4. So a lot of things are being done in the huddle, whereby roles and assignments are given. So in a typical ER shift, which I do mostly a night shift here, because I work a night shift in the US. Once we resume at 6:45 is the resumption time for the ER in the huddle. You must be in the huddle by 6:45 p.m. Then huddle is just for 8 minutes from 6:45 to 6:53. That's the end of the huddle in the ER room. So from 6:53, everybody moves to their different location for their assignment. So basically, I always work in the trauma room or in triage. That's where I work because that's actually key area I've been trained. Have some certifications in the emergency room since I came here. So that's the area I always work all the time. So in the trauma room, you have one person assigned to, you have 3 trauma room in a typical ER hospital. We have 3 trauma rooms. Then we have the triage room. So in the triage room, the nurse receives patients. That's what we call door to door. That means from the time the patient comes from, the time that you are seeing the patient to the time the patient is coming to meet you in the triage, that you should have to be from that triage room to the bed should be 5 minutes. It's a law in the US, in the ER. A patient should not exceed more than 5 minutes from triage to being assigned to the room. There are a lot of standardized ER terms we use here in the emergency room, such as the LPT. That means patient left prior to triage. We have what we call the LMFC, which is left prior to medical screening examination. Then we have some what we call the EMTALA violation laws, which is also so much important here in the US. And this is where it's quite different from the Nigerian system. There's no EMTALA in Nigeria. EMTALA is like Emergency Medical Treatment and the Active Labor Act. This violation has been in place for a very long time. It entails that you have to be able to make sure you don't violate rules in the emergency room. And the EMTALA law said that you must treat every patient, whether they are paying or they are not paying. You have to treat every patient. You cannot say no to a patient. They don't have money. No, you must treat every patient. So in the typical ER, the triage is so important, whereby you have to screen the patient and be able to assign whether it's going to acute care or it's going to chronic care in the ER. So there are a lot of things we do in the ER. We don't have that much time here to give you a full detail of everything, but I'm just telling you that the ER is a very interesting area that all of us have to experience. And it's quite different from what we know in Africa or in Nigeria, as an example. So you also have how we're able to prioritize patient in the ER room. So when a patient comes in, you have to be able to know what you need to do. For instance, that's what we call patient triage by the nurse. That's when a nurse knows whether this patient have to be a level 1 or a level 2 or a level 3 or level 4 or a level 1. For instance, we have for all chest pain patients in ER is being treated as a level 2 patient. For all chest pain, STEMI are all treated as a level 2 patient until proven otherwise. That means until you have done the EKG, you have done your CT scan or chest CT or angio. That's when you can say, okay, this will have to be a level 2, a level 1, or a level 3. But for every chest pain that comes to the emergency room, is a standard here in the US, you have to be a level 1 patient. Then for every AFib, that's atrial fibrillation, SVTs, or any abnormal arrhythmias that's kind of life-threatening, is being treated as a level 1. Whether the patient is breathing or not breathing, I have to be treated as a level 1. So the nurse in triage has to be equipped with knowledge and skills to be able to identify who a level 1 patient ought to be, because this is an area that will able to know whether your license in US is going to be safe or not. If you dare triage a patient as a level 3 when it's meant to be a level 1 and something happens, your license is in jeopardy. And I don't pray for anybody to experience such here in the US, because this is the area that everybody have to be at their peak. Most of us came from Nigeria as an ER nurses, but when they arrived US, they ran away from the ER. They went to med-surg. I know people have been asking me, how are you coping in the ER? You're always chatting, you're always communicating to people. I said, I enjoy my ER for the past 15 years now, be an ER nurse, and I've had some certifications to make myself happy in the ER emergency room. So I'm a registered trauma nurse. Also registered with emergency nurse, where we have 4-year renewal license. It's a license that I renew every 4 years. You have to write the professional exams to pass. And so you can't just work in ER here because you're coming from Nigeria. No. We have what we call a level 1 trauma center in US and a level 2 trauma center. I've been working in all those centers since I came. So you must be certified, you must have the skills and the ability to work in those areas before you can be able to say you are a trauma or you're an ER nurse. So for now, I think I have to pause on this note to allow the host to continue. Thank you.
Thank you so much, Isaac. When you get into that area, somehow I get lost. ER is one of the places I've not worked in the US. I've worked in every other place: ICU, med-surg, OR, step down. I've done all that, but I've not gotten the courage, to really go into the ER proper. But are there other terms that you guys use in the ED, that's emergency room, that you think that we might need, to know? or to get ourselves acquainted with?
Yes, so in the ER, we use specific standardized, we call them standardized emergency languages. For instance, when a patient is waiting in the triage room, and the emergency room is so complex and unique because everybody wants to be seen in the emergency room because we call it as a face-based unit. People can spend 2 to 3 hours in ER waiting to be seen by the physician or by the nurse practitioners. And sometimes people don't have patience to wait. So most of the time, people leave the ER without being seen by the physician or without receiving medical treatment on their own. Not because the hospitals don't want to see them, but because they are tired of waiting. I've been in a hospital whereby a patient was in the waiting room for over 6 hours in the US here because of how complex ER can be. So we have what we call the LPT. LPT means the patient left prior to triage. LPT, patient left prior to triage. That means patient left the ER room without being seen by the healthcare providers, whether the nurse or the doctor. That means patient just signing in the kiosk. A kiosk is a machine. It's a machine that's been situated in the ER room whereby a patient comes in and sign in using their what we call, we have different things they can use to sign. They can use their driver license to sign in. They can also use what we call their social security to sign in. So when the patient comes to the ER, they use their social security to sign in. That means they want to receive care. So when they sign in, the nurse in the triage crosses the patient over from his or her own system to be seen. But if the patient left the emergency room without being seen, it is called left prior to triage. It is not the nurse's fault. It's not the hospital fault. That means the patient was not even seen at all. Then we also have what we call the LPMSE. LPMSE means that the patient left prior to medical screening examination. LPMSE. The patient left prior to medical screening examination. That means patient has been seen by the triage nurse, but has not been seen by the doctor. There are two different things. The first one is that the patient has not been seen by the nurse or by the doctor. That's the first one, left prior to triage. A patient must be triaged before seen by the doctor or by the nurse practitioner. That's the rule. Unless it's an acute emergency or trauma, whereby the EMS rush the patient in straight to the trauma room. That is a different thing. But if a patient walk in to the door, to the kiosk to sign in, it must be seen by triage nurse. Then we also have what we call the code stroke. The code stroke means when should a nurse activate the code stroke in the ER? So when you look at the acronym of stroke, be fast, it's quite different. So there's a difference between theory and practical here. So let's leave the theory alone. This is a real life experience whereby you are seeing a patient. So when do you activate a code stroke? It's not all about be fast, knowing the acronym or no. There's a difference. So a nurse in triage must be equipped with knowledge and facet of knowing when to activate the code stroke. So who and what criteria should we call or should the patient met before a code stroke is that? So a code stroke in ER means that the nurse have seen that this patient cannot answer any question. Hello, ma. Good afternoon, ma. What's going on with you? He cannot say anything. Can you smile for me? He cannot say anything. Can you hold my hands really fast? Can you shake my hand? He's trying to hold your hand, but cannot hold your hand, cannot even squeeze your hand. Then what? So the criteria says if patients meet at least 3 of these criteria, activate a code stroke. So the triage nurse has a radio where he's working. Radio is a communication phone. Is a device. So you call code stroke. So the triage nurse move the patient from the ER, from the triage room to the CT room. That is the standard. So the rule says for a code stroke, within 45 minutes, this patient must have received a CT scan, must have received. Now, there's a new method of treating stroke in the USA. It's called tenecteplase. Tenecteplase is a medication that is being used to treat a patient who has stroke based on whether the CT shows is it an ischemic or thrombolytic. So the CT must show one that the patient met the criteria for tenecteplase. So tenecteplase is like before we have what we call the arteplase. Well, we have the new one we've been using since last year, 2024. It's called tenecteplase. So a patient must meet the criteria for us to determine whether we're going to deploy a tinnitus. And a tinnitus is a medication and it has its own protocol altogether. So I know one day I'm going to also find time to be able to devise how we can be able to understand it. There's a lot of protocol for tinnitus, but for the purpose of this presentation today, the code stroke must be activated if the patient meets the 3 criteria. And that's what I've explained now. And patient must be moved from the CT to the room. So the protocol says within 45 minutes of arrival to the emergency room, for a patient that has those symptoms, they must have done all those, and the doctor must have read the CT scan report and be able to determine whether to administer tinnitus or not. Then there's also what we call the ESI. The ESI criteria is used to triage the patient to know whether a patient meets have to be a level 1, level 2, level 3, level 4, level 5. We only have level 5. We don't have anything like level 6. And for us in the higher acuity center, like the major trauma centers, we only see more level 1, level 2. Like I said, that for all chest pain patients must be a level 2 patient until proven otherwise. Then the ESI says for a patient who has a fever, if a patient has a fever, an abnormal vital sign, like this patient has a heart rate of over 150, which is tachycardia of over 100, that patient must be a level 2. So the rule says in ESI says if a patient has 2 abnormal vital signs, that's the rule. If a patient has 2 abnormal vital signs, not blood pressure, the abnormal vital signs here is only on temperature, respiration, and heart rate, not blood pressure. In US, they don't really pay so much emphasis on blood pressure because virtually most people are hypertensive and most people are on treatment. But the rule says if a patient has an abnormal vital signs or like respiration is high or low, or heart rate is high or low, or the patient has a temperature above normal range, that patient has to be a level 2, has to be treated as a level 2 patient. So for all kids who come to the emergency room with temperature of maybe 103 or like 38.5 with heart rate of over 180 to 200, that patient has to be a level 2 because kids in ER, most of them suffer what we call a febrile seizure. A febrile seizure is whereby a kid comes in and they have been shaken at home and the parents does not know what to do. And one thing I love about African or parents all over the continent, especially those who are passionate about their kids, that when their kids has temperature, they always give them what we call the paracetamol or the Motrin. But most parents here, they barely give their children Motrin or everything that have to come to the ER. And this is where the nurse has to play their role. You have to educate them in triage as they come, even as they're being discharged. And that is how it was. So there are a lot of terms we also use. That's what we call the AMA, which everybody knows, I guess medical advice. The patient can decide to walk out of the hospital without telling you, and there's nothing you can do. Sometimes they won't leave the hospital with their IV line. Your own is just to call the cops on them, call the police to trace them and to be able to sort them out. So there are a lot of things we do here in the ER.
We're going to play it down a little bit now. So Isaac, when you come into the ER, you meet the kiosk and then you sign in. And then next thing is you're going to be triaged, okay? So can you tell us different departments, of ER where people can be triaged to possible options? You can go to maybe if it's a child, you go to pediatric side, something like that. I don't know. Can you because what we do here is mainly we are imagining a lot of people that are here on this call, they are all in their different countries. So we're trying to create that mental picture of what the hospital is all about. So can you tell us, like, when you come in after triage, where do people go to?
All right, thank you. So first thing is when a patient signs in the kiosk determines whether the patient is here for, let me use the word ABCD to EF. I want to start from ABCD now. So if a patient signing with, I have shortness of breath, I have chest pain, I have headache, I'm vomiting, I'm having diarrhea, I have my left ankle hot, I fell from the truck and I hurt my knee, I was driving and I hit a car. So it determines what criteria should the triage nurse group this patient, or which unit should I send this patient to. So when you see what the patient signing, so that's what we call a chief complaint. A chief complaint is what the patient is signing into the kiosk. That means this is what brought me to the ER. We have what we call the initial complaint. That means when the patient comes to the triage, the nurse asks the patient, what brought you to the ER tonight? Or what brought you to the ER today? The patient says, oh, I was driving around 7 p.m. and I got to the traffic light and I hit a car in front of me and my head is hurting now. Now, the triage nurse is going to try this patient as an MVC. MVC means motor vehicle crash. We call it in Africa, we call it motor vehicle accident, MVA. Now, the nurse asks the patient the question, was there airbag deployed? Airbag is a device inside the car that deploys when there's an impact, when you have a crash. The nurse asks the patient, was the airbag deployed? If the patient says no, that means this patient has lower injury. But the patient tells you that was airbag deployed, that means, so if airbag deploys in a car you are driving, it means that impact was high. Airbag does not deploy just like that. So these are the questions we ask the patient. Now, we ask the patient, what was the impact of the MVC? Was it front, rear-ended? Was it the driver's side? Was it the passenger side? Those things are criteria that determines the level of acuity you have to place the patient. If you tell me it was a front-ended, that means the impact was from the engine side of the car. That is the front end. That means I'm going to treat this patient as a level 2. A front-ended MVC means that it's going to be an airbag deployed from the steering rack. There's going to be an airbag deployed from the driver's side, and there will be an airbag deployed from the dashboard. If you drive a car, you also know that we have airbag in all these areas. So the impact is going to be higher. If a patient tells me this is where the impact with the MVC occurred. Now, if you tell me the impact is from the back, that is the rear-ended. That's what we call the back. The back is the rear-ended. That means those people at the back are the one that is going to have more severe injury. Now, if you say the impact is from the rear side, from the driver's side, that means I have to be looking at who was the driver of this vehicle or this car. So these are the areas. So for us, we're able to identify when they sign in at the kiosk, we send them to. So if a parent says, I've been throwing up, I have abdominal pain. Let's say I have right upper quadrant abdominal pain for the past 4 days, and I've been vomiting for more than 10 times today. Now, automatically, as a trainer, you know that this patient is a level 3 patient. For all GI, irrespective of whether it's a gallbladder, appendicitis, intestinal obstruction, for all GI, unless they have an abnormal vital signs. Remember, I said, for abnormal vital signs of respiration or heart rate, if they're abnormal, 2 of them are abnormal, you have to be a level 2. But for all GI, for all gastrointestinal patients that is coming with any complaint, it has to be a level 3, unless they have an abnormal vital signs. It is only when they have an abnormal vital sign can say they can now graduate from a level 3 to a level 2. Remember what I said, for all chest pain, you have to be a level 2 patient. So a chest pain does not tell you I'm coming to the ER. They walk in, someone says, oh, I have a chest pain since 2 o'clock. I have a chest pain since 2 hours ago. So how do you treat this patient? Automatically, for all chest pain, we don't allow them to sign in the kiosk. Once they're coming to you sign them from your room and they're holding their chest pain, you don't allow them to sign in. You move them straight from the lobby. The lobby is a place where they sit down to wait for their turn to be seen by the doctor. So you pick them up from the lobby straight to the room. Now the rule says you must create a room for all chest pain in the ER. The US is so passionate about cardiovascular system so much and the neuro. And this is an area they focus a lot. So in ER room, you don't wait for chest pain. In fact, they don't wait long in the lobby. You have to create a room for them to be seen. Whereas a fake chest pain or not, until you have done your blood work, you have done your EKG, that's when you will determine what you're going to say. So sometimes a mother comes in with a child of 14 years old and say, my son have chest pain. How would a 12-year-old have a chest pain? He's not smoking, he's not taking any hard drug, and he's having a chest pain. So sometimes, in fact, I've seen a story whereby a mother tells me, my 6-year-old daughter has a chest pain. How would a 6-year-old daughter have a chest pain? So remember, if they are coughing, when you cough for a long time, it can lead to a pain in the heart, but that's not a chest pain. So in US, we have flu-like symptoms, we have a lot of medical conditions. So that the parent is coughing and having a small chest pain does not mean the parent have a chest pain. So these are the things we see. Now, the triage nurse will be able to identify where to move this patient to. So the chest pain patient goes to either CVIMCU or go to IMCU. Now, CVIMCU is cardiovascular intensive care unit, and IMCU is the intermediate aspect of the CVIMCU. Now, the organ of them all is the ICU. So when you send a chest pain patient to CVIMCU, you have to do the EKG and you have to do the chest CTA to know whether they're having any form of stroke or they're at risk of having any form of cardiac issue. So once the triage nurse have done the EKG, so the triage nurse must do an EKG. Please note this. A triage nurse in an emergency room must do an EKG for all chest pain patients. This is a criteria. There's an EKG machine in all triage room, and the nurse must do the EKG for all chest pain patients. Because whatever happens from triage to room, if the situation gets worse, your license as a triage nurse is in jeopardy. Because the question they will ask you in the court is, did you do the EKG when you saw the patient? And if you say no, your license is gone. And that is why, so the US is equipped so much that you have all the things you need in the emergency room. There's no excuse for complacency or for not doing your job well, because you have all the equipment you need. So for all chest pain patients, you must do the EKG immediately you see them. In fact, the first thing the nurse should do is do an EKG to identify whether they're having any arrhythmia or not. Before you start asking them questions, when did the pain start? How long have you having the pain? No, these are not needed. And mind you, the questions you ask patient in the triage have to be within 2 minutes. You can't be asking the patient, is your wife at home? How many kids do you have? And emergency room, that's what we call the initial assessment. Initial assessment is what brought you now? Chest pain, that's all. I don't care about whether you have abdominal pain for like 10 days ago or you have headache. I don't care about that. What we care is that what brought you now. Emergency room is unique. That means, why did you leave your house tonight to the ER? Something has made you to leave your house. So if you're saying, I left my house because I have chest pain, that is all I need from you. I don't care about whatever happens about your lifestyle. That is how. So in ER, you have to be so much passionate about time. Time is brain. It only takes you 2 minutes to ask your questions. What brought you tonight?